this is a Toronto general uh, echo uh, session where they go over 20 views, 20 of the most common views, and you can start here. If you know these views, then you have a good appreciation for what it looks like. All right, so this will be the cut section of the heart, and this will be the actual echo, what it looks like. Okay, so again, this is your mid esophageal four chamber view. So remember, when you put the probe can be either in the upper esophagus, the mid esophagus, the gastric, or the deep gastric. Okay, once you see a semicircle either on the left or on the right, it tells you that's a TE. So you have to know that the study is a transesophageal echo. Okay, this is one of the thing that clue you in, because you can rotate the camera from 0 to 180 degrees. Okay, so at 0 degrees, the left side is going to be on your right, and the right is going to be on your left. Okay, if you switch it to 180 degrees, then it's going to flip. So the left is going to be over here, and the right is going to be there. All right, so this is your four chamber view. Okay, the left atrium is up here. This is your mitral valve, open and closing. This is your anterior mitral leaflet, and this is a posterior mitral leaflet. The left ventricle is there, and you can see the papillary muscle, just a little portion of papillary muscles. So this will be your anterior lateral papillary muscle, your posterior medial papillary muscle. Okay, ventricular septum, atrial septum, the right ventricle, tricuspid valve is right there, and the right atrium. Okay. For view number 2, then still your mid esophageal level 2-chamber view. And this is the cut section that you're looking at. So this is the anterior wall, okay? Anterior wall, inferior wall, left ventricular cavity, the mitral valve, left atrium. And you can see a little portion of the left atrial appendage. So to tie that, this is your anterior wall, 2-chamber view, anterior wall, and your inferior wall, the mitral valve, okay? So this is your anterior leaflet of the mitral valve, and this is, okay, this is the anterior wall. So that's why this is the anterior leaflet and posterior leaflet. This is your left atrial appendage right there, and that's where you're going to see blood clots. So you can see the camera is 90 degrees. So you have to look and take out the transesophageal probe, okay, and you have to look at the controls. You're going to have a button to change the degrees of the camera, and you're going to have controls that will anti-flex or retroflex the probe or move it from side to side. So 2-chamber view, anterior mitral leaflet, posterior mitral leaflet. This is the anterior wall, inferior wall. The left atrium is right there, left atrial appendage. Okay, all right, so this is a number 3. So it's still mid-esophageal. This is what we call the mitral commissural view. So you're not seeing much of the left atrial appendage. What you're seeing is the anterior wall and the anterior papillary muscle, the anterior lateral papillary muscle come off right there. And this is your inferior wall. So your posterior medial papillary muscle come off right there. So this is going to be your anterior mitral leaflet, posterior left atrium. This is at 67 degrees. Okay. All right. So number 4, this is a very important view. So if they're going to put something, they're going to put something on this view. So at your mid-esophageal position, it's about 130 to 135 degrees. And in this view, you can see your aortic valve, the root, aortic root, and the ascending aorta. Your left ventricular flow tract, left ventricular cavity. This is your anterior mitral leaflet, posterior mitral leaflet, left atrium. Very important view. And of course, this is your right ventricular flow tract. Okay. So you need to have a clear understanding of the view. So this is mid-esophageal long axis view, where you can see, because if you're looking for aortic dissection, this is a very important view because you want to make sure that the aortic root and the ascending aorta don't have any dissection. Or if you want to just look at the aortic valve, it's a very important view. Another important view is your mid-esophageal aortic valve short axis. So if you're looking for bicuspid aortic pathology, bicuspid aorta, unicuspid aorta, or something of that nature, then it's a very important view. Okay, so it's about 45 degrees mid-esophageal position, so you can see the aortic valve. Okay, this is your left atrium. This is the atrial septum. This is your right atrium. Tricuspid valve is right there. It's your right ventricular flow tract. Pulmonary valve is right there. And then the pulmonary trunk. Very important, the atrial septum is adjacent to your non-coronary cusp. So this is the non-coronary cusp. Again, non-coronary cusp. It appears in all exams. Okay? So you have to know that. So if this is the non-coronary cusp, this is the left and this is the right. Okay, they're going to ask you, they're going to put the pathology somewhere inside there and ask you where it's located. You would probably know what the pathology is, but you're going to get the naming of the cusp or the valve wrong. And then you're going to get a question wrong. You have to know the atrial septum is adjacent to the non-coronary cusp. This is the left, this is the right. Your left atrium is right there. Atrial septum, right atrium, tricuspid valve, right ventricular flow tract, pulmonary valve, 45 degrees. So this is, pretty much similar to what we showed you before with your aortic valve, the aortic root, ascending aorta, anterior mitral valve, posterior, pretty similar. Okay. And then this is pretty similar to what we showed you, but this is the mid-esophageal right ventricular flow tract view. So pretty similar. So this is the right ventricular flow tract right here. This is the pulmonary valve open and close the pulmonary trunk. This is your tricuspid valve. This is the right atrium. Atrial septum, non-coronary cusp. Non-coronary cusp. Right, left. So the aortic valve opens in a triangular fashion. Okay. This is your so-called bicaval view. This is your IVCT with your eustachian valve right there. And then this is your superior vena cava. It drains into the right atrium. Okay, it's 90 degrees. All right, so another important view is to look at the aorta, the descending aorta, because one of the requests for TEEs rule out aortic dissection, where the wall of the aorta rips into. So you have to look at this view. I usually, after I get my gastric view, then I straighten the probe, rotate it to 180 degrees, and then so it's it's either 0 or 180, and you get your nice cross section. There's a short axis view of the aorta. You can see the wall of the aorta. Okay, so if the wall is ripping too, you can see it easily. You have to move the probe up and down, up and down the esophagus, so you can see the lower portion of the descending aorta to the upper portion of the descending aorta. And you can also see the arch and the ascending aorta. So short axis view of the aorta. You can straighten it, you can lengthen it. So if you move from 0 or 180 degrees to say 90 degrees, to 90 degrees, you can get what we call your long axis view of the aorta. You can still see the wall. So if there's a tear, you can see the tear. This is your so-called transgastric view, very important. So you put the probe in the stomach. So you advance the probe into the stomach and you anti-flex. You anti-flex the probe. So if you have your index finger and you point your index finger upward, that's what we mean anti-flex. So the probe is in the esophagus, you anti-flex it, and you're going to get something looking like this. This is a very good transgastric view. We call this this is a short axis. Again, this is your anterior wall down here, anterior wall, and this is going to be your inferior wall. This is the lateral wall, and your septum is over there. Okay? So if this is your anterior wall, then this papillary muscle is going to be your anterior lateral papillary muscle. And then this papillary muscle is going to be your posterior medial papillary muscle. So again, they're going to put a pathology. They're going to probably show that one of these papillary muscles is ripped, is torn. And they're just going to ask you which one it is. And because you don't know the anatomy, you're going to get it wrong. So you need to know the anatomy. Okay? It's your gastric view. If you want to see this thing on the side, it's a transesophageal. This is going to be your anterior wall. And it's going to be your inferior wall, lateral septum. So this is your anterior lateral papillary muscle, the posterior medial papillary muscle. Okay. And you can get a transgastric two-chamber view. So it looks somewhat like your long axis view, or your transthoracic echo, but this is going to be your anterior wall. This is your anterior wall, and this is your inferior wall because of your orientation. When you're doing a transthoracic echo, you're above the heart. When you're doing a transesophageal echo, you're below the heart. You're behind the heart. Transthoracic, you're going to be in front of the heart. Transesophageal echo, you're behind the heart. So this is your anterior wall, inferior wall. So if this is your anterior wall, it's a mitral valve, so this is going to be your anterior mitral leaflet and your posterior mitral leaflet. So make sure you know the anatomy so you don't screw it up, because the question is going to be very simple, very easy, but because you don't know the anatomy, you're going to get it wrong. You'll probably get the pathology, but because your anatomy is not correct, you're going to get it wrong. All right, so this is your basal short axis. Look, you can see the mitral valve opening and closing 0 degrees. but it still remains, the walls. This is your anterior wall down there, inferior wall, lateral, and septal. So, and of course you have your mitral valve opening and closing. Okay. Your transgastric long axis view. So you see your aortic valve and the mitral valve together. Okay. This is uh, uh, your anterior septum and your inferior lateral. Uh, okay. 103, about 103, 100 degrees roughly. Okay. So this is supposed to be your transgastric long axis view. It's a little foreshortened, but sometimes when you're doing transesophageal echo, you don't get things looking just right. But this is supposed to be your left ventricle up top, the mitral valve, left atrium, your aortic valve, the aortic root, ascending aorta, and your ventricular septum right there. Okay, so 0 degrees, deep transgastric. So you have it way into the stomach, and you can get this view. Your right ventricular flow tract view, transgastric. That is, you of course remember. So when you're reviewing this, you have the cartoon on the side that will give you an idea of the anatomy. Okay, okay. You can see the papillary muscles in the RV. Okay, the papillary muscles, and then you can see your tricuspid valve, the posterior leaflet, and the anterior leaflet. 120 degrees. Then you pull your probe up, you now into the upper esophageal location, and you can see the arch, aortic arch. Because if you're looking for dissection, you have to look into the entire aorta, the descending aorta, the arch, the ascending aorta. So 0 degrees, and you can see the arch. So you can sometimes locate the arch vessels. You can do the short axis. When you do your short axis, this is your aortic arch right there, and then you have your pulmonary artery at 100 degrees. Then your ascending aortic long axis view, where this is your ascending aorta, your right pulmonary artery. Okay. And then this is your ascending aorta short axis. So your ascending aorta is right there. So go over the views, the ones that you need to, you need to know all of them, but of course, you need to know your four-chamber view. You need to know that very well. Your two-chamber view, the commissural view, you need to know that. The long axis view, you need to know that. This view, aortic valve short axis, you have to be very, very clear in that view as well. This one, okay. Somewhat know your bicable view, and then with the descending aorta, because if they're going to give you a dissection, it's usually going to be a descending aorta. The transgastric view, you have to know that, okay, and then your transgastric two-chamber view. So those views are very, very important, in order for you to make any meaningful assessment of what's going on, because you can't talk about pathology unless you have an idea where stuff is located. All right. So, and of course, we went over complications It's an invasive procedure, so the complications are not, once you follow the the protocol, complication less than 1%. We'll talk about laryngeal spasm, throat pain, shortness of breath, methemoglobinemia. You're gonna get this on the exam. You're gonna get this in the exam because it's a very testable question. Using benzocaine. Okay, when you spray the back of the throat, the benzocaine is going to convert Fe2 plus in the hemoglobin to Fe3 plus. The problem with that is that the Fe3 plus is going to bind your oxygen irreversible. So the blood which is supposed to give up oxygen to the tissue is not going to give up oxygen to the tissue. So the patient is going to become hypoxic even in the face of good oxygenation. And the treatment for that is methylene blue. It appears on all exams, so just telling you. Okay, so complications: hypotension, tachycardia, esophageal rupture, rarely death. The medications that we use, you have to know those: midazolam, Versed, fentanyl, Demerol. You use something for pain. You need something to sedate the patient. And you should be able to wake the patient up just in case of any adverse reaction. You can give medication that quickly reverses your sedative, especially if the patient developing lung problem. Left atrial appendage. So left atrial appendage is a case we actually did, and we postponed electrocardioversion. We gave the patient a little bit more anticoagulation, and then the cardioversion at a later time. Myxoma. This is not a transesophageal echo, you should know that, but we found the myxoma with the transthoracic, and then we'll move on to a TEE. Vegetation. So you know that this is a TE because you have your degree rotation symbol. Okay, so it's a vegetation which is on the posterior mitral leaflet, and this vegetation actually embolized, gave the patient a heart attack. When we talk about aortic dissection, so when you do your long axis view of the aorta, you see this membrane inside the aorta. It's not supposed to be there. So because the wall of the aorta rips in two, so the aorta is now double. So you put your color on, blood is flowing in this section. So this is what we call the true lumen. This is the false lumen, because your color going to show you, color Doppler that is going to show you flow. Okay, so flow in this lumen, no flow in that lumen. So this is your true lumen and your false lumen. There's a rip in the aortic wall. So some of the pathology that we can view looking at our transesophageal echo, we can see mitral valve prolapse, we can see spontaneous echo contrast, lipomatous hypertrophy of the atrial septum, vegetation on mitral valve, left atrial appendage, thrombus, just as a few of the pathology. All right, so that actually concludes our transesophageal echo lecture session. Okay, we will on Thursday we'll go over a few more pathology.